And here I'll talk to us about some side effects of immunotherapy from a lung cancer patient perspective. My disclosures are listed here. What we heard from Drs. Spira and Levy really is that immunotherapy is a potentially transformative treatment for advanced lung cancer. For the first time, we're really able to offer durable, meaningful responses. But with new treatment modality, we have new potential side effects. Now, just to clear some of the terminology, when we talk about side effects, that's the same thing as toxicities, and you'll hear the term adverse events, which is sort of clinical trial jargon, but they really all refer to the same thing. Immune-related adverse events are side effects that we attribute to immunotherapy via activation or enhancement of the immune system or of an immune response. And so Dr. Spira went through the mechanism of how immunotherapy works, but just to re-illustrate a particular point, shown here would be a T cell, one of the immune cells responsible for hopefully destroying some of the tumor cells. We have a T cell receptor shown here in yellow. That is what's responsible for recognizing the tumor cell, for example. There are other receptors on the surface of that T cell, including PD-1. Now, PD-1 serves as an off switch or a brake, and so when that is engaged, when that is turned on, then that T cell cannot activate. And so when a T cell recognizes a cancer and is hoping to destroy it, if the cancer then engages that PD-1, if the cancer steps on that brake, that T cell cannot be activated. However, we can pharmacologically manipulate that by giving an antibody that binds to PD-1 or its partner PD-L1, and in doing so prevents the tumor from stepping on that brake. Then when the T cell recognizes the tumor, that T cell can be turned on and activated, and then that T cell can then go target that tumor. But if that receptor is not expressly targeting the tumor, but is instead targeting the self or targeting some of your normal tissue, then when we turn it on, instead of targeting a tumor, it could target normal tissue, and that could lead to immune-related side effects. So immune-related side effects really represent the activation of immune cells in non-tumor tissue. And this can really mimic autoimmune conditions. So autoimmune conditions where our immune system attacks our normal body would include diseases like rheumatoid arthritis, myasthenia gravis, psoriasis, certain types of myositis, lupus, and in theory, immunotherapy in any form could really mimic a lot of these conditions. There are a lot of different manifestations of it. So the side effects with immunotherapy are quite different. And shown here is a diagram of the different organs that can be affected by immunotherapy. And really, it's everything. Every organ that you can think of can be in some way affected by the immune system and can be an adverse event associated with immunotherapy. So the side effects we encounter now with immunotherapy are very different from the side effects that are traditionally associated with chemotherapy and other traditional therapies. When we think of chemotherapy side effects, we think of nausea, vomiting, cytopenias or reduced blood counts, infection. Those are not typically things that we see with immunotherapy. In addition, the natural history is very different. And so because we've become accustomed to dealing with nausea and cytopenias, we've developed very sophisticated ways to manage those side effects and to prevent them. But when it comes to immunotherapy side effects, we have a little bit less experience with that. In addition, the natural history is quite different. If someone develops nausea with chemotherapy, we know that while we can manage it symptomatically up front, if we wait long enough, that side effect will resolve on its own, whereas an immune-related side effect, if not intervened upon, has the potential to persist and potentially continue to get worse, even if treatment is held. So I want to go over some of the specific side effects that we encounter with immunotherapy. Pneumonitis is an immune reaction that targets the lungs, resulting in inflammation and impairing function of the lungs, and it can present with varying severity. As we heard earlier, sometimes it's only a radiographic finding, but often it will cause cough or shortness of breath. Now, with lung cancer, a lot of our patients have cough and shortness of breath, so we're really looking for changes, a new cough or a worsening cough, and new or worsening shortness of breath. Oxygen requirements are important. If someone is not requiring oxygen, but now they are after immunotherapy, we worry about pneumonitis, and certainly it can be very severe and even life-threatening and even present as respiratory failure. And here's one of my patients. This is a CT scan. The orientation here on the left of your screen is her right lung. On the right of your screen is the left lung. This is the CT scan before treatment, and after treatment you can see this haziness on the left lung. This is a very severe pneumonitis on the left side, and this did indeed cause significant shortness of breath, but did improve with treatment. Pneumonitis is pretty uncommon with just PD-1 or PD-L1 inhibitors. The incidence is about 5% in most studies. It'll be more common potentially with other immunotherapy drugs and certainly with combinations. may also be more common in other diseases. We talked a little earlier about melanoma and lung cancer, both immunoresponsive tumors, but we see that the side effect profile with the different drugs and in the different cancers can be a little different. The key to pneumonitis, and really this will be a recurring theme, is that rapid recognition is really critical. If someone has new or worrisome symptoms that really should prompt imaging with a CT scan, a chest x-ray is generally not adequate in this setting. And when we identify severe pneumonitis, we need to stop immunotherapy, regardless of whether it's working or not, and really go the other way and start immunosuppressants to stop this process. That is typically with high-dose steroids, and that's often a long course of steroids. It does require close observation. In my own practice, that is daily observation in the hospital. The speed at which we recognize it does link with how well we can manage it, and this is a symptom that should not wait for 3 weeks or until the next doctor's visit. This really is something that deserves an urgent phone call. Colitis is an immune reaction that's targeting the gastrointestinal tract, usually manifests as diarrhea or blood in the stools, and this also can be severe and life-threatening. When we talk about colitis, it's important to note the number of stools. That's something we'll want to hear from patients. It is a little less common with the PD-1 and PD-L1 inhibitors than with the CTLA-4 inhibitors or with combinations. And again, rapid recognition. If there are mild cases and someone has a few episodes of loose stools, antidiarrheal medications like loperamide can be useful. Sometimes localized steroid therapy can control those symptoms, but severe cases will require high-dose steroids and hospitalization and often other immunosuppressive therapies. The management for most of these toxicities will also include a diagnostic workup to be sure that this is an immune-related side effect and not some type of infection or other complication that may involve testing of the stool or even a colonoscopy. Hepatitis is an immune reaction targeting the liver. This is typically noted with a laboratory evaluation and is often asymptomatic. This is something I would call a paper toxicity, where I will see it on paper before a patient will notice it. But if severe, it can cause fatigue, jaundice, nausea. We need to be sure that there are no other contributing causes of liver abnormalities, such as other medicines, herbal medications, alcohol, and so it's important that we provide that history to the treating doctor. Dermatitis is an immune reaction targeting the skin that's quite a bit more frequent than the other ones we talked about. Dry skin, pruritus, or itchiness are actually relatively common. Alopecia or hair loss is not common with immunotherapy, but it can occur. The rash that we see with immunotherapy can be mild, although it can be severe, and there have been reported cases of Stevens-Johnson syndrome, toxic epidermal necrolysis, and bullous pemphigoid, potentially life-threatening dermatologic conditions. Skin reactions in general are more common, but these are usually mild and often don't require any treatment, and I certainly have patients that develop intermittent rash for years while on therapy. Endocrine toxicities are immune reactions targeting endocrine glands, and these symptoms can be a bit more vague. So they're likely underdiagnosed. Target organs include the thyroid, the pituitary, the adrenal gland, and the pancreas. Thyroid dysfunction with immunotherapy is actually relatively common, though fortunately it is something that is easily fixed. It often requires replacing a hormone that is mixed. So in the case of a thyroid dysfunction, if the thyroid is not producing thyroid hormone, that's a hormone we can synthetically create very easily, a pill that you take once daily. In many cases, however, though, that is permanent, and that replacement will need to continue indefinitely. This is important to note. Adrenal effects could potentially be dangerous, and so in times of crisis, the body will make certain hormones through the adrenal gland. You may not realize that the adrenal gland is not able to do that until you are in a crisis. And so here's where understanding some potential toxicities of immunotherapy is important, not just for the patients, but for other doctors, for example, surgeons and emergency room doctors. So immune-related side effects can affect any organ. The most common side effect, really with all of our therapies, is fatigue. In this instance, it's really difficult to know if it's immune-related or if it's related to something else. It also may be linked to a different toxicity, such as hypothyroidism, hypogonadism, or adrenal insufficiency. And other mild side effects are possible, even common and likely underreported, and it's difficult to accurately attribute. Usually these don't require any intervention, and as patients remain on therapy for years, these occasional symptoms that come and go may just be part of normal life, part of normal aging, although they may be related to the immune system, doesn't necessarily mean we need to do anything different in management of the patient. But any organ is vulnerable. Some less common but important sites to remember: kidney, autoimmune nephritis, damage to the kidney; the heart, cardiomyopathy, and damaging how well the heart can work. Certainly can affect the eyes, causing uveitis or iritis or an inflammation of the eyes, altering tearing. Affecting the blood. While we often see that with chemotherapy and sometimes with targeted therapy, it can also be seen with immune therapy. However, unlike immune therapy, stopping the drug or waiting may not lead to resolution, and really that may need to be treated. Joint problems can be seen, and these can be quite durable and seen even after stopping therapy, and affecting the nerves can also be seen. So how do we monitor patients for immune-related side effects? Regular blood tests while receiving immunotherapy and beyond. But the important thing is direct and open communication with the treatment team. Anything notable and new needs to be reported to the physician. And I usually encourage my patients to keep a log or a diary so they can keep track of the different side effects they're noticing. I don't want to color the conversation in the wrong way, though. Despite all these possible toxicities, immunotherapy has been consistently better tolerated than chemotherapy, with lower rates of side effects, lower rates of severe side effects, and overall a lower rate of stopping treatment due to those side effects. So while it's important to know these possible side effects, to be able to intervene in a timely manner, overall these are safe and important drugs. So when do side effects occur with immunotherapy? Well, as Dr. Spira and Dr. Levy mentioned, the appeal of immunotherapy and what really makes these drugs important is their durability, the potential for long-term responses, meaningful benefit, invoking immune memory. And so that can make long-term responses possible, but it can also make long-term toxicities possible. And so when can side effects occur? Really any time. Some of our early data suggested that the majority of side effects occur within the first 6 months. Now, to be fair, during the first 6 months of therapy, there are more people on a trial receiving immunotherapy. And while there are curves that would suggest skin toxicity would occur first, followed by GI toxicity, followed by lung toxicity later, I think the important thing to remember is that that risk never really goes away. And these are idiopathic toxicities. They can occur very late. They can occur years after therapy, even while off therapy. And so it's something we will have to continuously remember in patients, even in the long term. The treatment for severe immune-related side effects is immune suppression, typically in the form of corticosteroids. Early and aggressive intervention is important for severe cases. When we stop the steroids, the side effects may recur, and so longer courses of steroids may be needed, at times even months. While you're on high doses of steroids, that increases the risk for potential infections and other complications, such as glucose and bone metabolism. When you have toxicities related to immunotherapy, lowering the dose of the drug or changing the schedule is generally not an effective strategy. So for chemotherapy or for targeted therapy, if you have a lot of nausea, we may wait till those symptoms improve, lower the dose, and then expect things to be better. That wouldn't exactly occur with immunotherapy. It really is immune suppression. And a concern we have, will immune suppression prevent the immunotherapy from working? So what if someone is on high-dose steroids for severe emphysema or for a transplant or other immune conditions? Will immunotherapy work in that patient? Well, generally patients that are taking high doses of immune suppression were not included in those trials. So the real answer is we don't know. We do try to minimize use of steroids. Concerns regarding steroids and impairing that anti-tumor immune response are common both among physicians and patients. And so there are cases where I will send a patient who's experiencing toxicity to an emergency room, and the doctor will be hesitant to give immunotherapy, worrying, or hesitant to give steroids, worrying that he'll undo what we've accomplished with immunotherapy. And certainly patients have the same concern. If a drug is working and we give steroids, will it stop working? What we've learned over many case series, mostly from melanoma but also from lung cancer, is that the responses can persist during and after steroid therapy, even in the absence of further immunotherapy. And so if someone experiences a severe toxicity, requires steroids, after they complete their steroids, I may not need to restart therapy if they've achieved a response. But if steroids are needed, they must be given, and they must be given quickly, because really these toxicities, if not managed appropriately, can be life-threatening, and safety is always our first priority. Everyone's treatment course really is unique, and immune-related side effects can be very unpredictable. We know that some patients may be at higher risk, particularly those who have underlying autoimmune disease, although specific determinants of risk are still being studied. Some combinations of immunotherapy may increase risk when we combine immunotherapy drugs to make it more likely to get an immune response. In theory, that can make it more likely to get an immune-mediated toxicity. When we combine immunotherapy with radiation, combine it with other drugs like chemotherapy or targeted therapy, that may change the risk profile, and certainly we have to watch out for those. Proper management for immune-related side effects really requires timely recognition and therapy. Immunosuppression, if it needs to be given, it needs to be given quickly. Rapid, honest, and frequent communication is important. Again, I can't stress enough, if you're noticing a severe toxicity, that's not something that can wait 2 or 3 weeks. What I find is more and more patients are increasingly considerate and worry that their doctors are very busy, they don't want to bother them. This is something I want to be bothered with immediately. Education and awareness is very important. Recognition is the key. This is both with patients, family members, caregivers, and providers. And we regularly talk to our emergency room doctors, our primary care doctors, and other people involved in the care for these patients to be able to recognize these toxicities and deal with them in a timely manner. With this in mind, though, immunotherapy overall, very safe and an important treatment for lung cancer. I will stop here to answer any questions before we move on to the next session.
Question: if the patient has stopped, if patient has stopped treatment doing well, does continuing to experience even a low-grade adverse event indicate that the drug is still working, or is that a myth?
So are immune side effects a biomarker for how well the drug is working? And there are some studies that suggest for patients who receive immunotherapy and develop immune-related side effects that some outcomes are a little better. But I would say that the evidence is pretty lacking. What it does show is that the immune system is being activated, that the drug is in fact doing something on target. Now, whether that translates to an anti-tumor response, not necessarily. And the converse is true as well. If you develop no side effects, it doesn't mean that the drugs aren't working. They could certainly still be having the desired effect. If my colleagues have anything else to add there?
I would agree. I think whether that means that obviously something has been triggered within the adaptive arm of the immune system, but that doesn't necessarily translate into further tumor shrinkage or tumor response.
No, I agree completely. I think one has to distinguish a lot from the targeted therapy, i.e. TKIs, where one sees that a lot and here not. And that's often a myth that actually many physicians also believe in as well.
I just want to add to the folks who are in the room, if you have a question, write it down and just wave to me and I'll come get it. Question: when can I restart immunotherapy after having a side effect?
So the short answer is it depends. So if someone has a severe toxicity, such as a severe pneumonitis or colitis requiring hospitalization, that could be really a life-threatening toxicity, I generally would not restart therapy in that patient. I think the risks of that happening again would be too great. Now, if someone had a mild toxicity where I held therapy and it resolved, then I would restart, accepting some risk and watching that patient pretty closely. And so it really is individual and unique. And this is an instance where experience with immunotherapy is really important within the center.
Yeah.
Your thoughts?
I don't know, we actually had some report on this at our last year ASCO meeting from Memorial, looking at re-challenging patients who had experienced a toxicity versus those. This is retrospective. This is just looking back to those that were re-challenged versus those that weren't. As Dr. Liu mentioned, I think a lot of this depends on the severity of the adverse event and how the patient looks. I think we have some data, albeit retrospective, that we can safely re-challenge patients who have minor or moderate adverse events and be able to manage those by re-challenging them. Whether those patients actually live longer or not versus not re-challenging is another story. This is all retrospective, and I don't think we have great data on how to manage.
I mean, as you said before, Stephen, this is not a situation where you dose reduce the drug. So you can't hope that if you go from 200 to 100 milligrams of the drug that the side effects are going to be less. It's usually all or none. So the good news is ASCO is coming out with some guidelines soon that's going to summarize all this. It's mostly common sense. It's also a situation where I kind of figure it out on the individual patient. If it's 3 months in, I try and get a CAT scan to see if there's clinical benefit. And if there's clinical benefit and a mild risk of getting worse, or if it gets worse, I think we can plow through it like just a bad rash. But if their PDL is low and they haven't responded and they had really bad pneumonitis, I think it becomes a no-brainer. You're not going to do it.
Now, there are some toxicities where we're very comfortable even treating through, for example, thyroid dysfunction.
Yeah.
If someone has low thyroid hormone, we can replace that. That's not even something that I would hold treatment for.
No, great point.
I'm not sure I understand this question. I'm just going to read it as it's written. Signs of adrenal problem again? Question mark.
Sure. So adrenal insufficiency can manifest in a lot of different ways. The most common would really be fatigue. If it's related to the pituitary, as in hypophysitis or a pituitary crisis, that can cause headache. That can sometimes affect vision or loss of vision or double vision. But adrenal crisis is a different story. And so in times of severe stress, such as the need for surgery or severe infection, our body relies on our adrenal gland to release certain types of hormones that can really keep us going. And the absence of those hormones can really be dangerous. And so if someone develops a severe infection and their adrenal is not working, then their blood pressure may stay very low. They may not improve without us replacing that hormone, without us giving steroids. Have you seen cases presented?
I'm gonna come clean on this one. So it's one of the hardest things to diagnose and find, and a lot of our patients are fatigued, a lot of them are tired. And I had a patient with a slightly low sodium, 120s, whatever, high 120s, a little tired, and ended up in the hospital for severe adrenal insufficiency. It is a challenging thing to do because it is a very rare side effect, and it's easy to miss among a constellation of other symptoms that our lung cancer patients have. So I saw that one, and now I think every patient is adrenally insufficient who's on until I figure it out otherwise.
But you make an important point. Electrolyte abnormalities, low sodium, high potassium can be seen in some constellation. And really the way to test for adrenal insufficiency is not so straightforward. It's not usually a simple blood test. You check a blood test, you give a medicine, you wait a half an hour and check another blood test. It's sort of an involved way to do that, but sometimes it needs to be done.